All right, today we're playing detective. We're diving into a real-life mystery, the case of stolen sleep. It's all about a condition that leaves millions of people totally exhausted, but, and this is the crazy part, it often gets completely missed by standard tests. So let's get into it. So does this sound familiar to you? You go to bed, you get what feels like a full night's sleep, 7, 8 hours, maybe more. But when you wake up, you feel like you've been hit by a truck. You're just dragging yourself through the day, and you have no idea why. Well, that feeling, that's our first clue. And that one clue leads us to a whole crew of accomplices. We're talking about a deep, crushing fatigue that's way more than just being a little sleepy. You've got that classic brain fog where you just can't seem to focus. Maybe you get morning headaches or find yourself feeling irritable for no reason. All of these things are breadcrumbs, and they're all pointing to a culprit hiding in plain sight. Now, whenever you talk about these kinds of sleep problems, everybody's mind jumps to one thing: sleep apnea. And, that makes sense. It's super common. But in this particular investigation, the usual suspect, it's often a dead end. So let's quickly review what we're talking about with classic obstructive sleep apnea, or OSA. This is when your airway physically collapses while you sleep, either completely or partially. This makes you stop breathing for 10 seconds or more, which, as you can imagine, causes your blood oxygen levels to plummet. Your brain freaks out, wakes you up just enough to take a breath, and then this cycle repeats all night long. It's a pretty dramatic event. But here's where the plot thickens. Researchers started noticing that a whole bunch of people had all the classic symptoms, the fatigue, the brain fog, but when they did a standard sleep study, the results came back normal. The tests couldn't find any of those big airway collapses or oxygen drops. The usual suspect had a rock-solid alibi. And this is where we have to pivot. If the airway isn't collapsing, then what in the world is robbing people of their rest? Well, the answer is way more subtle. It's not about the airway slamming shut. It's all about the constant struggle just to keep it open. And that leads us to our real culprit, upper airway resistance syndrome, or UARS. With UARS, your airway doesn't actually collapse, it just gets narrow. But that narrowing means your body has to work so much harder to pull in every single breath. And it's that intense effort, not a drop in oxygen, that sends an alarm to your brain, waking you up for a split second, potentially hundreds of times a night. This picture makes the difference so clear. Think about it like this. OSA, on the right, that's a total road gluck. Traffic stops, emergency lights are flashing. But UAS, on the left, that's more like a 5-lane highway suddenly squeezing down into a single lane during rush hour. Traffic is technically still moving, but it's an exhausting, high-effort, stressful crawl. Let's just break down the key differences here. With OSA, the main event is that big airway collapse. With UARS, it's all about that flow limitation, that struggle, which leads to an arousal. And look at the oxygen levels. They stay pretty much normal in UARS, which is exactly why the simple tests miss it. This also leads to a different kind of symptom. Not so much the I'm falling asleep at a red light sleepiness of OSA, but a deep, profound fatigue. And the final clue? Check out the typical patient, often someone with a normal or even low BMI, which totally shatters the old stereotype. This brings us to the smoking gun. The key piece of evidence in the case of UARs is something called a RERA. That's RERA, and it stands for Respiratory Effort-Related Arousal. This is the stealthy move the culprit uses to wreck your sleep. So how does this whole RERA thing work? It's a sneaky 4-step cycle. First, as you sleep, your airway gets a little bit narrow. Second, your body starts fighting like crazy to pull air through that tight space. Third, your brain gets an SOS signal that something is wrong. And fourth, bam, your brain hits a tiny panic button, a microarousal, just to get your airway open again. You don't even remember it, but this little cycle repeats over and over, all night long, just shattering your deep sleep. Okay, so if this is happening all night, why is it so hard to catch? Well, cracking this case means you need the right tools, and you have to know exactly which clues you're looking for. This is so important. Most of those at-home sleep tests, they're just not going to cut it for UARs. They're designed to find the big clues of OSA, those major oxygen drops and long pauses in breathing. But UARs doesn't have those. To catch this culprit, you need the full in-lab polysomnography, the PSG, which has EEG sensors that can actually see your brain's microarousals and measure that subtle effort of breathing. And here's how the culprit gets away scot-free so often. The standard score for sleep apnea is the AHI, the apnea-hypopnea index. It only counts those big collapse events. So a person with URAS can be suffering terribly, but their AHI might be less than 5, which is considered normal. They get told everything is fine, even though they feel like a zombie. But the real evidence, the thing that blows the case wide open, is a different number, the RDI, or Respiratory Disturbance Index. The RDI is smarter. It counts the big collapses, sure, but it also counts all of those sneaky RERAs we talked about. And when you look at the RDI, you get the true picture of just how fragmented someone's sleep really is. That's how you finally solve the case.
So, who is the typical UARS patient? Well, this is another reason it often gets overlooked. It's not the stereotypical older or overweight man. We're often talking about younger to middle-aged adults, very often women, with a totally normal BMI. The risk factors here are often more anatomical, things like having a smaller jaw, a high palate, or even just chronic nasal congestion. Now for the best part of any detective story, the resolution. The really good news here is that once you've cracked the case and have a proper UARS diagnosis, this is a solvable problem. There are excellent treatments that can stop the struggle and finally give you your life back. The most common treatment is positive airway pressure, or PAP therapy. You probably know it as CPAP. The idea of a pneumatic splint is perfect. It's just a gentle, constant stream of air that physically props your airway open all night long. If the airway can't narrow, there's no resistance, no struggle, and no arousals. It just stops the whole cycle before it can even start.
But that's not the only tool in the toolbox. For many people, a custom-fit oral appliance, kind of like a retainer that gently moves your jaw forward, can work wonders. And if the main issue is a stuffy nose, sometimes surgical procedures to open up the nasal passages can be a total game changer. It's all about finding what's causing the resistance and fixing it. And that brings us right back to the beginning. So many of us just accept fatigue as a final diagnosis, as something we just have to learn to live with. But what if it's not? What if that exhaustion you feel isn't the problem itself, but actually the biggest clue pointing to a hidden and highly treatable disorder? The case might not be closed. In fact, for you, it might be just getting started.